What are the major bleeding disorders and when do you have to worry? What are the major drugs associated with bleeding, either increasing your bleeding tendency, thinning the blood, or stopping bleeding, and how do they work? We're going to build on last week's talk on the normal cascades of bleeding, talking about primary hemostasis, coagulation cascades, and fibrinolysis. So let's get to it. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson, where we help you scale surgical education, give you the tools you need so you can be confident on your exams, but also in the operating room and on the ward. We put a bunch of videos together and getting some great feedback. So if you haven't had a chance to subscribe yet, hit the subscribe button, turn on your notifications, share this with your friends, and of course, leave comments below. If there's something you want some more clarity on, or if it's a topic you want to hear, definitely write it in the comments and I'll get back to you. Also, check out citizensurgeon.com. I have a lot of great resources there, and a new thing for this talk going forward is we're going to have some quizzes available. So if you want to take the quiz before the bleeding disorder video, go ahead, click on that, get over to Citizen Surgeon and do the pre-video quiz. Definitely after you've watched this, go ahead and click on the link to take the quiz to make sure you've gotten all the information. So today we're going to talk about bleeding. Now, why do we have to know this? We ask this every time. So why? Well, you want to know, if you're going to operate on somebody, is there a chance that they're going to have an increase of risk of bleeding during that procedure? You know, if I'm taking a baby to the operating room, what's their platelet level? Do I have to be worried about this? If you're taking a patient to the operating room and they've had a history of significant bleeding with a dental procedure, do they have an inherited problem with coagulation, like Hemophilia A or von Willebrand's disease? We're going to learn all about that today. In addition, if somebody is on aspirin or if somebody is on warfarin, what do you have to think about? Does somebody have vitamin K deficiency or liver disease? And how does that interfere with their clotting? So these are the things we're going to talk about today, and this is why you have to know a lot about the normal aspects of bleeding as well as when it can go wrong. The big goals for today are, in order to know abnormal, you have to know normal. And so if you haven't watched the first video on bleeding, go ahead, click over to that, watch that video. That's going to give you a really good description on primary hemostasis, fibrin formation, and fibrinolysis, and then you're going to be totally charged for this talk today. Our major goals are to do a quick review of the coagulation cascades. We're going to talk about primary hemostasis and inherited problems with primary hemostasis, as well as the several drugs that are involved in primary hemostasis. We'll go over to fibrin formation. We'll talk about the different coagulation cascades, what inherited problems are specific to those, and then of course, what drugs like heparin or low molecular weight heparin are involved in those coagulation cascades and how they work. Finally, we'll talk about fibrinolysis and disseminated intravascular coagulation, and then we'll tie everything together with a big table at the end, and of course, the post-video quiz. All right, let's do it. You know, the first thing to talk about is, when should you worry? And so what are some questions that you can ask your patient to be pretty confident that I either need to get a little bit more information and order some tests, or I'm good to go with respect to bleeding? So there are a few questions that you can ask, and they're all really easy and quick. So, do you have a history of a bleeding disorder? They might say, oh yeah, I'm a hemophiliac, or yeah, I have von Willebrand's disease. Have you ever had any abnormal anemia or any abnormal low blood counts or any history of bleeding? Have you ever had any abnormal bleeding tests or any abnormal coagulation tests? Is there a family history or positive family history of a bleeding disorder? And finally, do you take any blood thinning medications? So these are 5 easy questions to ask the patient. Just takes a moment, and this will really save you if that patient says, oh yeah, I had a wisdom teeth taken out and it just wouldn't stop bleeding afterwards. Or yeah, you know, I was playing basketball and I bled into my knee and I had to go have that looked at. Yes, I've needed multiple blood transfusions. So these are all questions, and you'll be surprised that when you ask questions and you ask direct questions, patients will give you answers that are much more specific than if you would have just asked an open question. So, hey, do you have any medical history? If those questions elicit some concern, then you can follow up with some diagnostic tests. You want to get a complete blood count and evaluate the platelets. you want to get your coagulation test, so a partial thromboplastin time, or a PTT, or a prothrombin time, which is your PT. If those come back abnormal, or you have some specific concerns that we'll talk about, for example, a specific concern about primary hemostasis or recurrent bleeding early after a clot is formed, there are some other tests you can get. So these might be the bleeding time, the thrombin time, or the activated clotting time. So there's some additional tests, but the first one's a CBC with platelets, a PTT, and a PT would be your initial diagnostic test for concern of bleeding. So let's kick it back here. We're going to review really quick what are those three big headings for bleeding. First is primary hemostasis. So that's where you get vasoconstriction, formation of your platelet plug. Second is fibrin formation. So there are those coagulation cascades. You get prothrombin to thrombin and fibrinogen to fibrin. And then finally is fibrinolysis, and this is dissolution of clot. All right, so again, if you haven't seen the video on bleeding, you want to get back to that, check that out. Otherwise, let's get going with primary hemostasis, drugs, bleeding problems. So when we look at primary hemostasis, we can see our cartoon here. We have our exposed subendothelial matrix after injury. That's going to set out this cascade where you get the linking between glycoprotein 1b von Willebrand and the exposed collagen of the subendothelial matrix. That's going to join other platelets with platelet aggregation. You're going to have degranulation of those platelet granules, which is going to cause more platelet aggregation as well as vasoconstriction. The platelets link together through glycoprotein 2b3a, and then fibrinogen helps link these, and then finally you get formation of that platelet plug. So there are a bunch of drugs that we can talk about here. So let's do that. First, aspirin. So aspirin, like we talked about, it's an irreversible inhibitor of cyclooxygenase that prevents the formation of thromboxane A2, and that is going to limit or inhibit platelet aggregation. So remember, if you have somebody that's on aspirin and you have that irreversible platelet inhibition, you're going to have to wait 7 to 10 days, which is the lifespan of those platelets, to be able to have adequate formation of that platelet plug. So let's move on. We got clopidogrel. So clopidogrel is a specific antagonist of the platelet ADP receptor, and that again prevents platelet aggregation. We have dipyramidol. Now this is a PDE3 inhibitor, so PDE3, that'll inhibit the breakdown of cyclic AMP, so you get increased levels of cyclic AMP, and that prevents blood clot formation and inhibits platelet aggregation. And finally, we have abciximab, so that's a very specific glycoprotein 2b3a inhibitor, and that again is going to prevent that platelets binding to each other through the glycoprotein 2b3a receptor, and again preventing platelet aggregation. So you have aspirin, clopidogrel, dipyramidol, and abciximab. These are going to be your major inhibitors of platelet aggregation. Now, while we're talking about drugs, is it possible to increase platelet aggregation? Well, one of the ways we can do this is through DDAVP or arginine vasopressin. What does DDAVP do? This is a great multiple choice question. So this releases those viable-Palade bodies in the endothelium, and they have von Willebrand's factor and factor VIII, and so they will increase primary hemostasis. We use this in liver disease, uremia, von Willebrand's disease, mild hemophilia A, and in patients who are having bleeding from aspirin. So this makes some clotting factors available to increase primary hemostasis. And so how about some diseases of primary hemostasis? All right, what can go wrong? What are the congenitally acquired conditions we have to worry about? So first is von Willebrand's factor. I'm going to jump out of the way for a minute. There's a lot going on with von Willebrand's disease, and I want you to see all of it. Von Willebrand's disease, it can be mild, and the mild form is about 1 in 100, so that's a lot of people. The severe form is 1 in 25,000, so the severe form is quite rare. There are 3 different types. Each of these has different subtypes, especially type 2, but I want you to take a look at this. So type 1, that is the most common, and this is a quantitative problem with von Willebrand's factor. So you either have decreased secretion or increased clearance of von Willebrand's factor, and this is mild bleeding or asymptomatic. These are the ones that are more common in our society, and maybe you'll see the patient will have a history of bleeding after a dental procedure or some other intervention. Type 2, over here on screen left, we're going to see a qualitative defect. So remember that. Type 1 quantitative or an amount. Type 1 quantitative or an amount. Type 2 is qualitative, so it's actually a defect in the von Willebrand's factor itself. And this has 4 subtypes. In 2A, you get no large von Willebrand's factor multipers. They help with platelet aggregation in that blood clot. Type 2B is increased glycoprotein 1T binding and rapid clearance. Type 2M is you can't bind glycoprotein 1B, and number 2N is you can't bind factor 8. And if you remember, factor 8 and von Willebrand's factor work together in primary hemostasis. Type 3, you have complete absence of von Willebrand's factor. This is the most severe and obviously the most rare, but this is life-threatening bleeding. It's autosomal recessive inherited. It also has extremely low factor 8. And then there are a couple other subtypes. Platelet type, which is a defective glycoprotein 1B receptor, and you get rapid clearance like type 2B. And then there's an acquired type, and you could get this in things like aortic valve stenosis if you have a VAD or ventricular assist device, and we see it in pediatric surgery in kids with Wilms tumor. Now, how do you treat von Willebrand's disease? Well, in the mild form, you can treat it with DDAVP. And this is type 1 and type 2A. If you have a quantitative defect, you don't have enough, or you're having increased clearance, then using DDAVP to release those viable platelet bodies and present more von Willebrand's factor, factor 8, will be very helpful. If you have a more severe type, like type 3, where you're not making von Willebrand's factor at all, or a qualitative defect in the protein like type 2B, 2M, 2N, then you can use medium purity factor 8 concentrate. The reason it's medium purity is it's not just factor 8, but it's factor 8 and von Willebrand's factor. So good examples of this would be Hum8P or alphanate. And then you can also use recombinant von Willebrand's factor, and that would be something like von Willebrand. All right, so there are a couple of other inherited disorders. You're going to not very often probably find these clinically, but certainly you get these on the test. And those are problems with either the glycoprotein 1B receptor or the glycoprotein 2B3A. So if it's the glycoprotein 1B receptor, that's Bernard-Soulier syndrome. And if you have an inherited defect of the glycoprotein 2B3A receptor, that's going to be Glanzmann's thrombasthenia. Now, when we get over to fibrin formation, we get into these coagulation cascades. So let's review these for just a moment. Now remember, you have 2 major pathways. You have your extrinsic pathway. We have that from injury, and then we have our intrinsic pathway, and we typically think of inflammation with the intrinsic pathway. These join up to a common pathway, and the full goal is to get fibrinogen to form into fibrin and to link that clot together. When we look at specific factors in each pathway, we can see here again that your extrinsic pathway, or the tissue factor pathway from injury, which is going to be factor 1 or fibrinogen, factor 2, which is prothrombin, factor 7 and factor 10. When we look at the intrinsic pathway, that's going to be factor 1, factor 2, but also factors 9, 10, 11, and 12. All right, those are going to converge on our common pathway, and that's factors 1, 2, 8, and 10. And those are going to help us achieve our goal of giving fibrinogen converted to fibrin. So we can see here in the extrinsic pathway, or the tissue factor pathway associated with injury, when we get activation of tissue factor and factor 7A, that's going to activate, remember these are serine proteases, so this is going to activate factor 10 to factor 10A. That's going to stimulate prothrombin to become thrombin, and thrombin, or factor 2A, is going to stimulate fibrinogen to become fibrin. Fibrin is going to go ahead, and factor 13 is going to cause this to be cross-linked, so it's a really stable clot. We can also see some cofactors and some positive feedback loops here with factor 5 and factor 8. And we can see how factor 8, factor 9A form this 10A's complex, which gives positive feedback for more conversion of 10 to 10A, and the cycle repeats itself for a stable clot formation. If we jump over to our intrinsic pathway for a quick review, we can see we get exposure of collagen, then we get our pre-kallikreins and our high molecular weight kallikreins, and those are going to stimulate factor 12 to factor 11 to factor 9, which is going to stimulate factor 10 to 10A, and then the cycle repeats right through prothrombin to thrombin and fibrinogen to fibrin. So there's a lot of stuff going on, but once you understand these two main differences, extrinsic going through factor 7 right to 10A, and the intrinsic going through collagen exposure, those kallikreins and factors 12, 11, 9, and then 10, you're going to be set for those MCQs that really try to trick you on these factors. I'm going to bring it all together in this cartoon, and then we're going to use this cartoon here, which has the intrinsic pathway and the extrinsic pathway joining for the common, and this is where we can really understand the different drugs and the different disorders in fibrin formation. So the first drug to talk about are our vitamin K antagonists. So this is Coumadin, or you'll see it as Coumarin or Warfarin, and so really important drug because this is ubiquitous in our community and a lot of people on it for blood thinner. And so how does this work? Well, vitamin K antagonist is actually an inhibitor of vitamin K reductase, so it inhibits the recycling of vitamin K from the inactive to the active form. And these are factors 2, 7, 9, and 10, as well as protein C and protein S. But the major effect is on the extrinsic pathway through the inhibition of factor 7 and factor 10. If somebody is on a vitamin K antagonist, we can follow this through the prothrombin time, which is really the test we use for the extrinsic cascade. And related to the prothrombin time is the INR. Now remember, the way you get your prothrombin time is mixing a patient's plasma with tissue factor, and that's going to show you the presence or absence of those factors or their inhibition on the extrinsic cascade. The tough thing about vitamin K antagonists is their dosage and effect can be variable depending on levels of albumin, the presence of vitamin K, and of course clearance by the liver. One thing with warfarin is you have the presence of this initial hypercoagulable state, which is why bridging with something like heparin is a good idea. And so why do you get that hypercoagulable state? You get that because the vitamin K dependent factors 2, 7, 9, and 10, which are prothrombotic, have a longer half-life than the protein C and protein S. Now we haven't talked a lot about protein C and protein S, but they inhibit clot formation. And so their short half-life, when you give warfarin, you initially get a drop in your protein C, protein S concentrations, which leads to this hypercoagulable state. And in patients that have protein C deficiency, when they get warfarin, they can have something called warfarin-induced skin necrosis, which is clotting the epidermis and leading to skin necrosis. And that can really be a horrible consequence of warfarin. I've seen it in a couple of patients, and it has devastating results. Moving on to heparin. So heparin is a really common drug we use for anticoagulation. The way this works is heparin, when we think about these different medications for anticoagulation and their mechanism, heparin is definitely the least specific. So heparin is it's a naturally occurring glycosaminoglycan, has a variable in size, and it is not selected out for just the low molecular weight. So that would be low molecular weight heparin is a fractionated heparin. And the way that it works is it really accelerates the function of antithrombin 3. So it binds to antithrombin 3, and then you have increased inhibition of factor 10 and thrombin. And those are two extremely important clotting factors in the common pathway. Now you follow this with your prothrombin time, which is the lab test for the intrinsic pathway. And again, the way that this works is when they mix the plasma to determine what the PTT is, if on mixing you get correction or normalization of the PTT, then you know that your increased PTT was a result of a factor deficiency. But in patients that have heparin in their blood and heparin in their plasma, when you do a mixing study, the heparin inhibits the factors in the mixed plasma, and so you get prolongation of your PTT, and that's how you know that heparin is in there. If you're wondering why a patient has an increased PTT, you could also have an antiphospholipid antibody would be another reason somebody might have an inhibitor in the plasma leading to an increased PTT. But the PTT, that's how you follow heparin. If you need to know what immediately in high dose heparin situations, like let's say you're putting somebody on extracorporeal membrane oxygenation, ECMO, or let's say you're putting on cardiopulmonary bypass, you can use something called the activated clotting time. So the activated clotting time is going to tell you what your heparin level is and if you're sufficiently anticoagulated, and that's for use in rapid or high dose heparin situations. When we look at low molecular weight heparin, so this is when you fractionate it out to just the polymers, the low molecular weight, and this is fractionated heparin, and this also binds antithrombin 3 in this specific inhibition of factor 10A. It has much more predictable clearance and a longer half-life than unfractionated heparin, and you can't follow this with the PT or the PTT. If you really wanted to follow it, for instance, in bariatric surgery or in patients with a high BMI, we can get a factor 10A assay, and that's going to kind of tell you the effectiveness of the low molecular weight heparin that you're giving. Another drug with a similar mechanism of action is Fondaparinux, so these are the pentasaccharides. Now this has specific binding of antithrombin 3 to inhibit factor 10A. So again, specific to factor 10A, doesn't affect thrombin. And in addition, it's not an antigen for platelet factor 4. So platelet factor 4 is an antigen that is implicated in heparin-induced thrombocytopenia. And so when you're giving heparin, where you get thrombocytopenia and actually increased risk of both bleeding and clotting. So now we've looked at the medications or the drugs involved in our fibrin formation. So just a quick recap, we have our vitamin K antagonists. So that would be your coumarins, and that's factors 2, 7, 9, and 10, as well as protein C and protein S. And then you have targets of antithrombin 3, and these targets would be unfractionated heparin, Lovenox, or the pentasaccharides or Fondaparinux. And so let's kick over and talk about some of the diseases associated with fibrin formation. So factor VIII deficiency, or Hemophilia A, this is an X-linked recessive condition, so you usually see it in males who are inheriting it from their mother as a carrier. There is a spectrum of the disease where it can be mild versus severe, and severe can be life-threatening bleeding after surgery, life-threatening bleeding after injury or trauma. And some of the things in these patients' history will be bleeding into joints or significant bleeding after intervention. And you can diagnose it by getting your factor VIII levels. Now for the treatment, these patients in the mild form can have DDAVP. So remember, DDAVP or arginine vasopressin is going to stimulate the release of those viable platelet bodies, and that's going to give you more von Willebrand's factor and factor VIII. In the more severe form, you're going to have to give recombinant factor VIII both preoperatively and postoperatively, sometimes for a week or a couple of weeks, to make sure that there's no bleeding. And so factor IX deficiency, so we can see this is also on the intrinsic cascade. This is Hemophilia B, or Christmas disease, not named after the holiday, but named after Steve Christmas, was the first patient who was identified in. So you can get an increased PTT with a normal prothrombin time, and this is again X-linked recessive, and the treatment is with factor IX, or recombinant factor IX, or tranexamic acid. And tranexamic acid, which is medication that helps increase clotting, should be used in procedures in patients with factor IX deficiency. Now moving on to liver disease, we can see that liver disease has a whole bunch of factors involved. So if you have liver disease, none of these factors are working properly. So these are factors 9, factors 11, factors 8, factor 10, factor 13, 7, prothrombin, fibrinogen. So the liver is responsible for most of the cofactors for clotting. And so if you have severe liver disease, you're going to see that first your prothrombin time is going to go up because factor 7 is the shortest half-life. Eventually your PTT will also be raised. This can be associated and worsened with vitamin K deficiency. And then you would treat this with both fresh frozen plasma, which has the cofactors in it, as well as vitamin K. And we're going to talk about fresh frozen plasma in the next video, which will be on transfusion. Now we're talking about vitamin K and vitamin K deficiency. So remember, these are factors 2, 7, 9, and 10. You see this more commonly in newborns because they don't have any gut colonization, so sometimes they need some extra vitamin K. Remember that vitamin K is absorbed. It's a fat-soluble vitamin. It's absorbed in the ileum, and it needs bile acids for absorption. So if you have malabsorption, like Crohn's, cystic fibrosis, celiac disease, you're going to have vitamin K deficiency. Now, you can have initially a prolonged prothrombin time, but you can also have an increased PTT, and you would treat this with vitamin K. And so, pretty complicated. We talked about a bunch of drugs as well as the inherited or congenital problems in fibrin formation. Now let's move on for a quick description of fibrinolysis again. So remember, fibrinolysis or clot dissolution, the main activator there is plasminogen, and so activation of plasminogen through urokinase or tissue plasminogen activator, TPA, leads to plasmin, and plasmin is going to break down fibrin into those fibrin degradation products. Your D-dimer would be one of the more important ones that you can measure. We see this increased in patients with a DVT, pulmonary embolism, or of course DIC. Now DIC we talked about a little bit in the last video, but it's worth going over again. So DIC, you have a major clinical event. So that can be sepsis or septic shock, massive transfusion, trauma. That's going to set off two cascades. One is going to be increased fibrin deposition. And the reason you have that is you have a few things going on. One, now remember back to the metabolic response to injury video, you have increased tumor necrosis factor alpha, which is very stimulatory in injury, and a lot of cascades associated with inflammation. So you get increased fibrin deposition. You're also going to have lower levels of antithrombin 3 and lower levels of protein C and protein S, which is going to lead to increased fibrin deposition. And that thrombosis leads to end organ failure because you're not getting your blood supply. At the same time, on the other side, you're getting consumption of cofactors, consumption of platelets, which is going to increase your tendency to bleed. So in disseminated intravascular coagulation, you have an intense inflammatory condition which has set off these two cascades, one leading to fibrin deposition, clotting, and organ failure, and the other leading to platelet consumption and cofactor consumption, which is going to increase your bleeding. And so let's summarize it up. We talked about a lot today. And a nice way to summarize this is with a big, scary table. So in this table, you're going to see a few things over in the first column. Going down, we have thrombocytopenia, prolonged bleeding time. Third situation is where your PTT is prolonged, but your prothrombin time is normal. The fourth down there, so you have an increased PT, but a normal PTT. And finally, what are the conditions in which you have both an increased PTT and a PT? And so you can go down here on the second column is going to be the different conditions. So for example, if we looked at it when we have PT is prolonged, but our PTT is normal, that could be in factor 7 deficiency, vitamin K deficiency, or mild hepatic deficiency. Let's say we have a prolonged bleeding time. So we're going to see these in different platelet disorders. So that could be von Willebrand's factor, but it could also be that Bernard-Soulier disorder or the Glanzmann's thrombasthenia. Also, remember uremia, liver failure, or if you're on a drug like aspirin, that prolongs the bleeding time. And then in the third column, I have some different tests that you might want to order to get more specific and find out exactly what the bleeding problem is so that you can treat it effectively. All right, so that is bleeding disorders and drugs. To summarize this, just remember, think of it in 3 different sections. So primary hemostasis, fibrin formation, and fibrinolysis. Each of those is going to have their different elements and different drugs and diseases, but if you have a good idea of how each of these functions normally, it's going to be much easier to remember either how these drugs work and how you can reverse them, or what bleeding problems you should be concerned about. So I hope you enjoyed that today. We covered a lot of information. Again, subscribe to the channel, leave your comments below, share it with your friends. If you want to see that you've totally nailed it today, go ahead and click on the quiz. I have a post-test quiz with a few questions to kind of gauge whether you're still at that intern level and you need to do some more reading, watch this video again, or if boom, you're an attending, you're crushing it, and you know everything there is to know about bleeding. So be well. We got the next talk's going to come out on transfusion, and that's going to kind of close out this 3-video series on bleeding, and I'm looking forward to that. We should have that out for you in the next week. All right, take care, be safe, be healthy.